Bootcamp podcast. I'm Holly Hopley, the CEO.
And I'm Megan Busk, the head of marketing.
And today we are really excited because we have Dr. Bell on. If you guys have heard of Doc and Doula, you guys have your own podcast and you're all over social media and all that stuff. So we're excited to have you here as a guest we're going to talk all about induction today. So will you do us the pleasure of just like introducing yourself, tell us who you are, where you're from, what you do, all that fun stuff.
Sure. Bill Chun from Doc and Doula. I'm a solo practitioner, OBGYN. I've been in practice for 30 some years. I am here in Boston, my home away from home. I think the reason I started Doc and Doula a few years ago is because as a solo practitioner, without having any obligation to keep my mouth shut, I could say about anything, about what's going on. And I think we can all agree that we can do a lot better than what we're doing right now.
Yeah.
And that certainly applies to induction of labor.
Yeah.
So I think because I am self-employed, I don't have any filter. And I think that's important. If I were to work for any large hospitals in Boston, then I would not be talking to you today. So I like the freedom, but freedom has its price in that I have to work 24/7, just like you.
Yep.
But if you think about 2023, now 2024, I just don't see the trend getting better. So when I look back as an intern at Boston City Hospital, I don't really remember inducing people because as an inner city hospital, people just came in and labor and delivered. And our cesarean section rate was 13%, 1-3.
Yeah.
Now the rate is, in some settings, like the hospital I work out of, is triple that.
Yep.
And if you think about anywhere from 30, 40, maybe 50% of women are being induced. So why?
Right.
That's the question.
Yep.
Yeah. This is a tangent of mine. Do you feel like that has any effect on the ARRIVE trial that came out a few years ago?
I see my younger colleagues quoting that study that came out in 2018, but the study is not applicable to the general population. If you look at the study, the makeup of the study is totally different than what we're dealing with. And I would just say, as an OBGYN who not only delivers, but also does a lot of GYN surgery, I mean, I'm looking at the uterus. I just had 2 cases this morning. I look at the uterus and wow, how is that small organ gets so big and able to grow a little human being and then goes back? And if we talk about the anatomy of a typical uterus, it's a simple organ, right? It has a covering, it has a muscle layer, and then an inner layer. It's not like there's a brain or anything, but it's a mystery. And we're trying to tell Mother Nature what to do. And I have learned less I do, the better. Less exams, the better. I don't talk about induction. I wait unless topics are brought up. I don't talk about them. But what happens right now? Let's say 35-year-old first-time mom with an IVF goes in for first prenatal visit. Within the first few minutes, either because she's over 35 or because of IVF, induction is going to be brought up.
Yeah, she's immediately set at high risk, right? So
yes. So for the next 30 some weeks, that's all she's going to Google and think about. And that versus me telling my patients, the secret to good pregnancy is forget about pregnancy as much as possible. Just live your life. eat what you've been eating, do what you've been doing, travel, do as much as possible. Forget about pregnancy. And then at some point, you'll have your baby. But we're not letting women enjoy their pregnancy. That's the problem.
Yeah.
And as long as current insurance financial system is in place, meaning C-section pays about 15% more than vaginal delivery. So take the same patient. When she goes into labor, say Dr. Jones on Friday night around 10 o'clock, you know what, Jane, you've been in labor all day, and I just don't think you're going to deliver vaginally. And occasionally you see these little blips. I don't think baby likes your contraction. I think we should get your baby out while we can. So Jane is going to say, oh my God, all I ever wanted to do was be a mother. Okay, doctor, whatever you have to do, I don't care. I just want to have a healthy baby. So 10 o'clock Friday night, Dr. Jones do a not clearly indicated C-section versus if Dr. Jones gave Jane a few more hours, 4 o'clock on Saturday morning, she delivers vaginally. But if Dr. Jones let Jane labor and deliver 4 o'clock Saturday morning, he's going to get 15% less for his service. And he's also going to lose 6 hours of sleep. So why would Dr. Jones do that?
Right.
Yeah.
That's not going to change. That's just the way it is.
Yeah. And
it's unfortunate because we are scaring women about pregnancy. Pregnancy is a natural process, right? Yes. But for the most part, I think women do not need to be induced. Take common soft indications. In my mind, anyone over 35, IVF, high BMI, gestational diabetes without control, borderline gestational hypertension, large baby, small baby, 40 weeks, 41 weeks. All these are not clear-cut indication for induction. And I would agree if we really knew how to induce people, because we don't. In 30-some years, the methods for cervical ripening, medications haven't changed. And younger generation obstetricians are using that Foley catheter, balloon catheter, which is so uncomfortable.
Yeah.
And they are forcing something that typical body isn't ready for. So the consequences are increased C-section, postpartum complication, including postpartum hemorrhage. Postpartum hemorrhage is in such an increase in recent years. And I think that has to do with induction, therefore transfusion. And above all, these poor women, mothers, are not able to enjoy those initial days of that miraculous process. And what happens? That affects postpartum recovery. As it is, we don't support women anyway. So now is postpartum depression and anxiety an issue? Of course it is. But the doctor or doctors or midwives who started the process, their hands are washed because, well, according to guideline,
we did what we were supposed to do.
Exactly.
Healthy baby.
And remember, a lot of doctors are what I call shift workers. They don't stay with the patient for the duration. They do their 8 or 12-hour shifts. So if same Jane, because she's 35 IVF, was admitted at 39 weeks, because it's the first time, first pregnancy, it's going to take a day or two, and maybe 3 days from the time of the admission to delivery. If it's 3 days, that's possibly 6 different providers. Every provider has a different outlook. Every provider has a different exam. Why is that when you ask women, hey, Jane, who delivered you? Jane will say, oh, I don't know. There were so many. And if they are in teaching hospital, oh, I don't know. I think it was a medical student, maybe a resident. I don't know. Can we do better? Yes. We can do better by, like what you're doing, prepare them, give them information, childbirth class, support them through doula, so that give them information, consistent support using a doula, so that they have some understanding of what is about to happen and do what they want to do rather than doing what they're told.
Mm-hmm.
Because medicine is business like any other business, because there's transaction with money. If my Chinese restaurant did not have good service, bad food, or dirty linen, no one's coming back, right? But people tolerate this, and people are not voicing enough of what is going on.
Mm-hmm.
I mean, we have to, I mean, I want to almost say, you know what? If your C-section rate is 50%, I want to post that. Dr. Jones' C-section rate is 50%. Don't go to him or her.
I feel like
Mm-hmm.
I remember hearing that there was a hospital in California that did that.
Well,
And they posted like their C-section rates and their induction rates. And they were like, this cannot continue.
it
Like,
cannot continue.
yeah.
But from hospital point of view, maybe it's different in California, but if I'm a CEO of a hospital that is maternity, the difference between 100 vaginal versus C-section rate is between, for vaginal is $20,000 to $30,000. For C-section is about $50,000.
Mm-hmm.
That's $2 to $3 million. I
Yeah.
need that revenue. I'm not going to discourage my OBs from doing a C-section. I
Right.
need the
Yeah.
revenue. So how do we change this? Because doctors and other providers aren't really going to, there's no change coming. American
Right.
College of OBGYN is not going to do anything.
Mm-hmm.
Some academic physician on NPR talking about what to do isn't going to change anything. We have
Right.
to, each patient, we have to tell them, get pregnant when you are at your healthiest state, mind and body and otherwise. And then once you get pregnant, stay healthy, but pick the right provider.
Mm-hmm.
And understand what happens in pregnancy,
Mm-hmm.
and tell people what you want to do.
Yeah.
I mean, you know, I'm going to give an extreme example. If a 43-year-old woman who had a 2 C-section and she wants to try a trial of labor after C-section, and she couldn't find anyone locally, so she drove an hour and 30 minutes each way for my care.
Yep.
She ended up with her 3rd C-section, but at 42 weeks, because she got to try.
Yeah.
And she would have been happier if she had a vaginal delivery, but she got to try. She got to wait it out.
Mm-hmm.
Right.
Rather than being told at first visit, you know what, you're 43. You had 2 C-sections. Let's just schedule a C-section in 39 weeks.
Mm-hmm.
Mm-hmm. Yep.
How would
not,
you, oh, sorry,
Go ahead.
I was just going to say, what are some tips or ideas that you can give our listeners of how they can find the right care provider? Because that's where it really starts, is finding somebody that is going to align with what you're wanting and who is going to have these same philosophies. So like, what are the nitty gritty questions that people need to be asking?
I mean, I think the first issue is that the resources are not even across the country.
Yeah.
I happen to be in Boston. If I throw a stone right now, I'm going to hit at least half dozen OBGYNs because there's so many.
Mm-hmm.
But you go to the middle of Mississippi, I mean,
Right.
more than half the counties in this country do not have a single OBGYN.
Yeah.
There's a problem.
Yep.
So I like midwifery care. I think the model of midwifery care with an OB works really well. Therefore, for example, in Boston, Mount Auburn Hospital, I think is the best maternity hospital. Why? 40 midwives.
Wow.
Oh, wow.
That's amazing.
The hospital C-section rate is under 20%.
Wow.
That's awesome.
Versus 35%. That's a
Yeah.
huge difference. And so I like midwifery care if possible.
Yeah.
And of course, midwifery care gets a little tricky because not all midwives are the same. You know, we have certified nurse midwives, we have certified professional midwives, and then we have certified midwives, and then we have lay midwives. So there are 4 different types. But if my wife, if let's say I own a Chinese restaurant and I know nothing about medicine, and I were to find or look for an OB provider, I think I would really do homework, like we do when we look for a house. What do we do when we look for that car that I've always wanted to buy? Right?
Yeah.
I'm going to test drive them.
Mm-hmm. Research them.
Research.
Mm-hmm.
Research is available online. And I mean, I get tons of requests to find a provider. I always ask for their zip code. And what I do is I do online search. I don't find a person on the first page or 5-star. I look for just details. You know, anyone, it may be someone with a 4.7, but all positives, you know, it's a paragraph rather than one sentence. But certainly lots of information available online. Talk to your friends. And if possible, I would call and say, hey, can I speak to Chun for 5 minutes? Because I'm 35, first pregnancy. I just want to speak to him just to get a feel for it, you know?
Yeah.
And sometimes you may have to write maybe detailed little email and say, hey, here are the questions I'm going to have. You know, what is my prenatal care like? When am I seeing? 8 weeks, 10 weeks? And how many providers will I see? What is the call coverage like? And when will I be seen for postpartum? And you just have to do research rather than just, you know, just going by what your friends say, because I know it's not easy, but we are out there. There are still many of us who believe in medicine. And I want to say, despite medicine being a challenge, I think I picked the right profession, and I still feel the same way. I think medicine is about helping people, helping women in this case. And if you have that approach, I think you're going to serve people well. And there are still, I have colleagues who still believe in the same philosophy. Of course, there are many who don't, but
right.
You know, you just have to find them.
Yeah.
Well, and a lot of times you can ask doulas and childbirth educators too, and because they know, they work with the providers and they're like, okay, this one's good. This one's, you know, that's what I recommend. Find some doulas and some other birth professionals and ask them, because they'll tell you who the providers are too.
I mean, if every pregnant woman had a doula, that would solve our problem. And if we had, and you may agree or disagree, but I think I really do believe doula concept is very important. And this is where you may disagree, because I think you need a national entity to regulate. Because I don't know if people really understand that not all doulas are the same.
Right.
You have a great training program and you cover from A to Z, but there are programs where it's like Saturday and Sunday and they get certified. And because of the word certification, people don't have a clue, right? But doula really, it's not the doctors, midwives, it's doulas. So you got to talk to your colleagues and bring this together. That's how you solve this problem.
We're very passionate about doulas as well.
Yeah. When did you become so passionate about induction? And I see you talk about like induction on social media a lot and stuff, like, and why do you think that is so important that we get the word out there about, like, you know, not everybody should be induced, you know, we really should lower this induction rate? Like, why do you think that's so important?
First of all, I'm going to send you some goodies. We have no induction merchandise like tumbler, t-shirt.
Oh, I am totally down for that.
Because in medicine, we're supposed to do the right thing. Why do unnecessary things? Especially if we are not good at it. And also the negative effects of induction, which is postpartum. So unnecessary induction causing or increasing C-section with complication affecting postpartum recovery. I mean, it's that simple.
Yeah.
And we're not good at it.
Right.
I mean, we suck. I tell my patients, why don't you induce people? Because I'm not good at it. I don't know how. 2 things I say more than anything: I'm sorry, and I don't know. I say that all the time. When will my baby come? I don't know. You know, and I'm sorry. But I think at least 2/3 of women undergoing induction do not need to be induced. Of course, if you have preeclampsia,
right,
ICP,
yeah.
I mean, there are indications.
And that's what we say. We're like, there's a time and a place for everything. But like, it's what's important is knowing when that intervention is necessary and why and how to do it.
And people don't understand that when you are scheduled for induction, first of all, it may not happen on that day, because most maternity units, what has happened with pandemic? Staffing shortage. So I tell Jane, you know, call Monday morning at 7 o'clock to see if there's a space for you. But if there's no space, and 2 nurses called out sick, then Jane, who told everyone, guess what? I'm going in Monday morning. I'm going to be induced. And people are calling, oh my God, what are you doing? Are you dilated? Blah, blah, blah. No, I'm still home. I'm watching Netflix because there's no space for me.
Yeah. I've been in this exact position, and it brought so much stress to me because I was like, I don't know when this is happening because it's been delayed so many times. So I understand that for sure.
And even if you go in, if this is your first pregnancy, it may take days.
It's going to take a while.
I know of a case where first-time mom was brought in because of her age. I think she was 36 on Sunday. And she had a C-section on the following Saturday for failed induction.
Oh my goodness.
Now, why wasn't she sent home? Well, she didn't go home because she was brought in because she was supposed to be induced because of her age. So she's nervous. I mean, what happens if I go home and something happens? So each doctor who came on, oh, she's not my patient. I'm just covering. I just do this, do that. And then come Saturday, patients say, you know what? Where's my baby? And the doctor comes on and says, well, you know what? We tried everything. So if you want, I can do a C-section for you. By now, she's tired. So she has a C-section. Does it happen? Of course it does. It happens often. And I mean, you know this, I will say, being an obstetrician, being a physician in 2024, it's tough. Unless your heart is in it, I could not do this because of money, you know, because I have to pay my ex-wives or my kids. I couldn't do it. I think I just open a food truck. It's too damn hard. But we could do so much better. And I have to, as you brought up before, you got to find the right provider. And if you have to drive an hour, it's worth it. A third of my patients are from another state.
Wow.
And I mean, driving an hour each way is just what a lot of my patients do. Now, when they come into my office, they know that I never cancel my patients. I don't reschedule them. And I like to have my office be like airport terminal. It runs on a timely manner. There may be one person because I want them to in and out. And whenever I see them, I don't rush them. I sit down, I cross my legs, and I lean back and say, hey, so Holly, what's going on today? What's the weather like in Utah? Blah, blah. How's the family? Eventually. So I may actually only spend 10 minutes. But Holly thinks, wow, you know, every time I go see Chan, I have like the best visit. We have these long conversations because I listen. And we can do that.
Yeah. I've heard you mention a few times that we don't have the correct, or we don't know the correct way to induce. Do you feel like there is a correct way for induction? Or do you feel like it just in general, like, you know, we have the tools, but, you know, it is what it is?
I think the options we have, chemical versus mechanical. Chemical, you know, we have oral, vaginal, either 2 types of prostaglandin. One costs nickel, the other one costs $500. So often we are told to use cheaper one, which is the pills. I like the Cervidil, which is vaginal insert that stays in for 12 hours. That costs $500. But regardless of which one, it's the timing. So if I have to induce somebody, even if I were to buy 2-3 days by seeing the patient in my office, maybe do a non-stress test daily, by 2-3 days. And when I do an exam eventually and see that cervix is soft, like tip of your nose, your lips rather than tip of your nose, or slightly dilated, if I think I can bring a patient in and from the time of admission to delivery is about 24 hours, I think it's the right time. But whether it's chemical methods or mechanical method, it's hit or miss.
Yeah.
That's the problem.
Yeah.
And often, I'm going to say younger OBs, they're in such a hurry. They feel like they have to do something.
Mm-hmm.
But sometimes doing nothing is better. But, you've heard the story, the balloon catheter, it is uncomfortable.
Yep.
But that's all we have. In 30-some years I've been doing this, we don't have anything new.
Yeah.
And if I tell you, I was trained before the age of cell phone. Now I have my iPhone 15 somewhere. Technology has come a long way.
Right.
Yeah.
But why don't we have anything new for induction? Because it's a mystery. Pregnancy is a mystery to me. We use this due date, which is just date, right? Approximate. People say, well, how come it's 40 weeks? I said, well, we took thousands of babies from Utah, Texas, Japan, and Korea from the first day of last menstrual period to the delivery date for average size baby was about 278 to 279 days. That's how we came up with 40 weeks.
Right.
But why do we have to get stuck with that?
Yeah.
But without really knowing how a patient will respond, I'd rather not start.
Yeah.
Because if I start something, then the patient, her partner, or family members will have an expectation.
Right.
So I'd rather not start. So typically what I do is I'd rather not, unless there's a medical indication, in which case I do. But I will wait up to 42 weeks. And between 41 and 42, I may see that patient every day because some of them prefer. But waiting, but at 42 weeks, even for me, I like to have them be in the hospital and at least be monitored and do something. But yeah, no good method of induction.
No,
and the problem is all these, if you look at, I think Evidence-Based Birth is a great website. But if you read that on any topic, at the end, what does it usually say? More research is needed. No strong data. Speak with your provider.
Yeah.
Right? And that's where we're at. And I just really feel we need to educate women and leave them alone.
Yeah, I love that.
Let them be.
Yeah.
That's why the sweatshirt, I think it says, let me labor.
Yeah, I love that.
Let me labor and no induction is the items we made. So
yeah.
I'll send you some.
Yeah, I'm down for that. I'll wear that all the time. That'll be a good conversation starter.
Yeah. So, but it's I think when I think about that process of baby coming out of this, one of my tools here, the toilet paper tube, I say this is a size of vaginal length and the width. When I see that baby coming through, wow, it never gets old. And because I deliver my patients, it's always, we have a plan, and I like the environment to be just calm. I don't, I prefer just one person, usually me saying, hey, push, stop, push. I like laboring down as long as possible. It's not 30 minutes. I mean, if I find my patient is fully dilated, I kind of walk away. I watch Netflix. And then she said, you know what, Chon, I got to poop. Maybe that's time. right? But that process is so amazing. You've been there.
Yep.
And I often ask my patient, hey, do you want to deliver your baby? And many of them do. And for them to reach down, grab the baby, that new being on their chest, best thing is just kind of walk away, no clapping. At some point I will. At some point I'll ask, hey, do you want to cut the cord? And I actually think it's so amazing. If the mother cuts the cord, it's so symbolic, I think, rather than FOB. What did he do? He's got his mother. What you do? You do your part. And when that happens, the lights are dim, maybe some soft music, just walk away. And then I check to see if there's any laceration. If there is, I make sure that the patient is comfortable, and I do repair. At some point, I think, placenta, you look for signs. I don't do anything. At some point, I deliver the placenta. If not, I will wait. If I have to wait an hour longer, I wait. And then afterwards, I do think getting Pitocin is a good idea, because if there happens to be any kind of bleeding, then all of a sudden you got to, massage the uterus. You got to do this and that. It interrupts that initial hour. So there are so many little things we could do to let that mom enjoy that hour or longer, That versus C-section.
Yep.
Right? And sometimes these C-sections are done in the middle of the night when everyone is, they're cranky, they're not courteous, and nothing goes well. Happens all the time. But I think if we did things right by minimizing induction, our cesarean section rate could be in teens.
Yeah, I agree.
So maybe 1 out of 7, 1 out of 8 or something.
Yeah.
Not 1 out of 3. And that's what we got to do. That's what you got to do. That's what I got to do. Let them know it's very possible.
Yeah. Yeah, I think so much of it is education. It's just, it's getting them to learn about all of this stuff, and really getting them to ask questions. We really encourage everybody that we teach and all of our doula clients, go and have these conversations with your provider. Ask them, when do you, prefer to induce your clients, and why and how, and all, really have these good conversations with them. Because I think that I really wish that our society and culture would look at the client and doctor, look at it as a relationship, not just you're the doctor, you know everything. I'm going to come in and just listen to everything you say and do what you tell me to do. Yeah. I'm this is a relationship. Let's have these conversations.
Exactly. And I mean, it's funny because when you check into the hotel and you get your room is not the one you booked, or you get a wrong dish, I mean, people can be really rude.
Oh, yeah.
People can be really rude on the road, the way they drive.
Right.
They can be rude on internet, comment, oh, Chun, oh my God, worst OB/GYN ever. What the fuck? You should do that with your provider, because you are paying for the service. You're not giving, I mean, your hard-earned money. Somebody's paying for it. You got to demand that quality.
Yeah.
If the visits are 5 minutes, next time maybe bring a long list of questions. Because the provider will not leave, doc, I have a list of questions I like to go through.
Right.
Then the provider is not leaving until you're done.
Right. Yeah. Or if they do, then you need to find a different one.
Yeah. Red flag.
Yep.
And there's a thing called online. You can always, like Yelp or something, say, hey, the food sucked, doctor sucked.
Right. Yeah.
And I would say, I cannot tell you how bad some of these doctors are. So after I stopped, I delivered my last baby vaginal, lovely delivery in October. And then I wasn't going to do any OB at all, not even any prenatal care, but patients asked and I felt obligated. So now I provide prenatal care up to sometime in third trimester. And I refer them to a few of my colleagues to whom I would send my daughter to, because I know them. They practice good medicine, and they're nice people.
Yep.
Then there are others in the hospital who suck. So I tell my patients, if you choose to go to the ones I do not approve, then I'm going to drop you as a patient.
Yeah.
So do I, you know, because it's just, there are good ones and there are certainly bad ones. And there are ways to have a positive experience.
Yeah.
And I want to say over and over and over, traumatic birth experience lingers for a long time.
Long time.
Yep.
Long time.
It's like, you know, in some ways, probably worse than a divorce. I mean, it lingers for a long time. It affects that person as a new parent, affects your job. There must be a reason why so many women are on medications for anxiety and depression.
Yeah.
Right? It lingers. So if we say prevention is better than cure, then we really have to make the effort, and certainly each patient has to do her part.
Yeah. Yep. Yeah. This is one of the most important, if not the most important day of your life. Like, is the day that you give birth.
Yes.
And it's so worth it to invest in like having the right provider and, you know, taking a good class, hiring a doula too. Like, that's part of all the prevention is to like, let's do everything to help put all the cards in your deck so that you can have the best experience possible, so that hopefully you can avoid a traumatic birth. And I have found that when you do that, even if you do end up needing a cesarean for whatever reason, there's less trauma because you understand like how you got there and you had support and you were part of that process and not just like laying in bed and told what to do. And so, you know, they see exactly what happened to get them to that point where they needed a cesarean, and they're like, okay, it's necessary. I did everything I could do. For whatever reason, it didn't work out the way we wanted it to, and that's okay. And so then we find that there's less trauma.
Yeah, I mean,
that's been our experience.
Yeah, I mean, that's what I tell my kids. The process is more important than the end result.
Right.
So you got to really learn to enjoy each process in anything we do in life.
Right.
But I really appreciate the work you do. And when I was at that DoulaCon last September, or I think it was in September, we are really trying to do good work. And I think women are responding, which is amazing. And hopefully in time, it'll be widespread change. But we just got to keep it up, keep yelling, voicing, and trying to make a difference with each person.
Yeah. I view it as we help improve birth for one client at a time. And then that will help spread because they'll go tell their friends that, hey, you don't have to be induced, or, you know, telling their friends, you really should hire a doula. So it really does, like, we can do this one woman at a time. And hopefully it will spread and improve the situation for everybody.
I have a nonprofit that is in its early stage, doulasforeveryone.org. Really, my hope is that we can provide doula service for everyone who needs one or wants one, and not having to worry about the cost, because often the cost is an obstacle. Hopefully in time, we can have it available in every state. Right now, it's just in Massachusetts and Tennessee. But, you know, it's, I really believe in doula, doc and doula. It couldn't be doula and doc, so I made it doc and doula.
Yeah, it does. It has a little bit more of a ring. Yep. Cool. Well, this is great. I think that's a great place to kind of finish things up. Is that we're all working together to just improve outcomes for women and families and babies. And I think that's what it's going to take, is a whole community of people to do that. So
well, let's stay in touch. and I will share with you some stuff coming up. Because as of next week, what I wanted to do was really have almost like virtual prenatal content available. So as of Monday, every Monday, I want to talk about preconception topic, Tuesday first, Wednesday second, Thursday third trimester, and then Friday postpartum topics.
Awesome.
And I'm going to have live events where I invite you, talk about your work, and really have people engage so that there's a reliable content that's available. And if I could have all the experts come to one place and share what we do, I think women will really benefit. So
absolutely.
It's going to launch as a Monday. So
awesome.
Right after this podcast, I'm going to record that stuff.
Nice.
There you go. Great. Awesome.
Can you tell us where to find you?
Doc and Doula on Instagram, TikTok, and docanddoula.com is the website.
Okay.
Yeah.
Awesome.
Well,
perfect.
I hope to see you again in person at next DoulaCon. I think we're having another one in 24.
Yeah. Sounds good. Awesome. Well, thanks for hopping on here and talking with us today. This was fun.
Thank you so much.
All righty. Okay, you too.